behalf of Region 7 and the Ask for Respect Supplemental Grant, we want to welcome you to our series of interviews focusing on the perils and pearls of lessons learned regarding COVID-19. Our hope is to share the lessons our colleagues have learned and to assist you with your healthcare journey during this pandemic. Thank you for listening.
Well, hi, everybody, and welcome today. And I'm really excited to have a chat with you all about our topic of interest today. So really about kind of the managing of a pandemic and sort of what have been your experiences and learning so far. So first, I'm wondering if we could start with you telling us your name and what your role has been through the pandemic. So Margaret, maybe we'll start with you.
Hi, my name is Maggie Cullather, and I currently support Barnes-Jewish Hospital with the Emerging Infectious Disease Program, which is the program that oversees Ebola preparedness in the biocontainment unit. My role has been fluid throughout, I think would be the best descriptor. I definitely spent quite a few months in our emergency operations center throughout the first few months of the pandemic, and since then have been supporting a number of different working groups that have objectives in managing the pandemic, as well as making sure that we continue to keep up our Ebola preparedness, as that will inevitably be critical going forward as well.
Yeah, I think it's so true, right? There were a lot of things that were very similar, but many that were phenomenally different. So thank you for that, Maddie. Jason, let's go to you next.
Hi, my name is Jason Campbell, and I'm the manager for emergency management and continuity of operations for the hospital. During our first activation, I supported the hospital serving as an incident commander in partnership with Emma and our WashU emergency management colleagues. During the second operation, we've taken a more appropriate role as an EOC manager and making sure that our executives are functional and purposeful in their incident command and coordination of policy and strategy, and just helping bridge the gaps between their leadership decisions and operations to support response and recovery.
Thanks, Jason. Emma, let's go to you next.
Hi, I'm Emma Hooks. I'm the Director of Environmental Health and Safety and Regulatory Compliance at Barnes-Jewish Hospital. I also have oversight responsibility for the emergency management program, and in addition to that, support Maggie with the emerging infectious disease or emerging illness management program, or commonly referred to as Ebola program. So I did partner with Jason through the journey, first activation for COVID response and recovery, which commenced in March of 2020. Actually, activity commenced in January, but full activation started in March, and we finished, I believe, with that activation towards the end of June. And then the second activation occurred in late October and fully engaged in early November, and it continues. I think at this juncture, we're looking to transition from full activation to phase 2, I think, Jason, is that correct?
Yep, stepping back to a partial activation.
Yeah, sustaining this from a command structure for a long period of time has been a huge learning in and of itself. So maybe we can dig into that a little bit more in a few minutes. Stephen, let's go to you.
Sure. My name is Stephen Liang. I'm an emergency physician and infectious disease specialist at Washington University in St. Louis, as well as Barnes-Jewish Hospital. I've been working mostly on the clinical front in our emergency department, as well as in the hospital, and also am an associate hospital epidemiologist. So I've been supporting mostly our emergency department response to the COVID-19 pandemic.
Great, thanks, Stephen. So why don't we start with you, Stephen? Can you tell us a little bit about, there were so many learnings in the pandemic so far, and obviously we aren't done yet. But what was your biggest aha moment? Like, whoa, didn't see that coming, total surprise. Was there anything like that?
There certainly were many kind of aha moments, I guess, throughout. And I think things that we've learned a lot. I think the biggest thing that came out of this was kind of the close integration, I feel, of infectious disease physicians, intensivists, and infection preventionists as subject matter experts within a medical branch in the incident command system. And I think that definitely struck me as both essential and very prescient, very forward-minded thinking to involve these kind of specialties in ICS. Many of these folks have never really had direct experience with the ICS structure, and it really kind of the involvement of these specialists, as well as the kind of the professional emergency managers on this call, really promoted kind of sharing of information between ICS and frontline clinicians, as well as feedback from the frontline back to the ICS.
You know, I think I would say too, the involvement of physicians in a very big way for this sort of response was very helpful to us in emergency management. I mean, I think it's really opened the door to their involvement in a big way in other sorts of events too, whether it be this sort of hazard or something else. So that's great. Let's go next to Maggie. Maybe Maggie, what was your biggest aha moment? Were there things that you, as sort of the special pathogens leader, thought, wow, didn't see that coming, or wish we could have, considered that in response?
I think one of the big aha moments for me was seeing the real true interdisciplinary nature of an emerging illness specialist. One of the things, especially in the first activation, that I noticed was, my involvement, and by extension, the program's involvement in the EOC wasn't just limited to a siloed SME, but I was sitting in with the planning section chief. I was working with our decedent affairs working group. I've worked with our crisis standards of care working group. And so there is so much that comes from an emerging illness preparedness program that can relate to a wide variety of branches within an ICS structure. And particularly in a pandemic, there are lots of different aspects that can be pulled from a preparedness program like this that we already had in place. And so I think that for me was a big aha moment to know that, we really weren't just creating a program for Ebola preparedness, but that these concepts related really at its core to a successful response operation.
Great. Yeah, different pathogen, different transmission route, but really a lot of the same principles and key safety pieces. So Jason and Emma, you said a lot about your role in the EOC, and then I think about Emma particularly with your emergency management component and really safety being at the forefront. Is there anything from a preparedness perspective that you felt like throughout the response, really you had to adapt and change as you've activated twice and are still in the throes of your second activation? So Emma, you want to go first?
Yeah, good question. So is there anything, just to make sure I understand the question, I believe the essence of it was, did I recognize opportunities in the first activation that were actually improved upon or implemented in the second activation, correct?
Yeah, correct.
Perfect. Yes, the answer is definitely yes. The first activation, there were many discussions, obviously, due to the requirements for personal protective equipment and safe work practices. So a lot of developmental work, given what was available readily. And the methods of communication and making sure that we were effective with the modifications that were necessary in order to manage and support a COVID PUI or actually diagnosed. I would say in the second activation, PPE was readily available. Safe work practices were already defined. Collaboration and process improvements were well detailed. We even had an education program that we had developed in the first activation that we revised and actually launched under an electronic education and training program. That was a major commitment. But the biggest difference was, I would say, more emphasis on employee exposure prevention. It was there in the first activation, but in the second activation, we were on it as far as implementing our management processes for ensuring compliance and interviewing staff to understand during contact tracing, understanding behaviors inside the hospital and behaviors outside the hospital that ultimately resulting us in better tracking and better improved responsiveness in refinement, engaging our department leaders, and ensuring the implementation of safe work practices and the proper use of personal protective equipment. Where we actually saw the impacts of those enhanced practices. That's one thing that comes to mind. I think the emphasis on preventing employee exposure, so our workforce was at the bedside where it needed to be, and not perhaps recovering from or managing themselves through a post-exposure event.
Great iterative learnings, it sounds like, from the first to the second. But
Yeah.
you know, I'm also struck by, I think we all experienced similar things in that, you know, the first activation, really, most places were in lockdown, right?
Yeah,
So it was really
easier.
during the second one, it was much easier in some ways. You know, PPE was a challenge and other things like that. But
Right.
in the second activation, it really felt more like, you're right, you know, we had to really work with our team members on behavior outside of work.
Yes.
And yeah, all of those key things. So, Jason, what would you add?
Regarding kind of how our emergency management program may have adapted as a result of COVID, kind of the point that I really gravitated towards was a change or an adaptation in training philosophy, in particular with incident command system training. So pre-COVID, we had a classic traditional model that had all of your dry ICS courses, 100, 200, 700, 800, 300, 400. And it was a progressive curriculum that different operational leaders and emergency management committee members were able to advance through to upskill their foundational knowledge for the performance of incident command. But I think, as we all can relate to, the scope and the complexity both of our COVID response changed rapidly and dramatically, just even in the first initial weeks of our response. And we were tasked to rapidly upskill some leaders that had zero ICS exposure, familiarity, or experience. So recognizing that we had to solve for that training gap in an expeditious manner, we couldn't provide the full curriculum that we would normally do. And so instead, we had to elect to focus on the principles and the core concepts of incident command, what makes it effective, and training to that, and allow our operational leaders to find their own path towards success. So as we had about 40 minutes with our new leaders as they came in to step foot into incident command, and we focused on those principles, so such as management by objective and the chain of command and unity of command, span of control, just emphasizing what operationally would make incident command successful and effective and purposeful in our organizational response, and allowing them just how to interface with their counterparts with incident command, who do they report to, and making sure that they knew the parameters of incident command rather than all of the nuance of what does a finance section chief, data collection manager do. So really reassessing what components and what elements of ICS training are the most meaningful and translate them most effectively into a healthcare environment. What was a learning opportunity, and we applied it with a second operation with greater diligence and better outcomes as a result.
And I would add to that, great job, Jason, describing, because that was an aha moment for all of us as leaders in the incident command were challenged with all of our executive leadership team as they came in one by one to support us. But I also really appreciated willingness to roll up their sleeves and get down to the tasking. But I wanted to also call out that we actually saw some really good collaborative relationships built, especially with our medical branch and our infectious disease specialists and infection prevention specialists collaborating with what has not been a tradition in this organization, but effortlessly and seamlessly with our industrial hygiene and safety discipline people. It was really, you might say, an aha moment to see our chair of our infectious disease division from the university get up and walk to the table next to them where the safety officers were sitting and really get into some very, just wonderful discussions about personal protective equipment, about safe work practices, and about the unique uniqueness of each division, our ICUs versus our medicine units, and transitioning people and what people were used to doing on a daily basis, especially our peri-op people, and understanding the uniqueness and what they were used to and what we were going to ask them to do that was new and different, and to build synergy. And that synergy has actually carried over during the second activation. We continued those discussions by scheduling meetings once every 2 or 3 weeks, and we would just let the discussion evolve with our WashU EH&S partners, our infection disease, and I would like to also open it to our emerging illness program manager as well, where they just discuss what they've experienced and how they can support each other in their purposes. And I certainly will take that as a very long-standing memory from this pandemic response.
Yeah, those are very well taken points, and in all of emergency management, we talk about the 3 C's: communication, coordination, collaboration. I think about the examples you shared and how we stretched our workforce, right, to do different and unique things, but we drove home the culture of safety. And it probably also, I think, elevated really the importance of your special pathogen preparedness pieces too, for hospital administration, for the community, for the general workforce who may not have even known much about it. So that's really neat. All right, so let's go back to Stephen. And Stephen, if you were to say what you think the greatest sense of pride during the pandemic was, what would you say that was?
I would say it's witnessing firsthand kind of the adaptability and the courage of our frontline clinicians, staff, and leaders to operate under very uncertain circumstances. These are circumstances where knowledge and strategies are continually evolving related to screening, testing, isolation, and admission to the hospital. How to do this safely has been a moving target ever since February, March of 2020. So just kind of that adaptability. Also kind of courage to stand up again when that uncertainty to take care of patients has really inspired me. And also kind of the kind of can-do attitude. I mean, I think a lot of, we talk about span of control and also setting objectives and so forth. And I think one of the things, because of the scope of this pandemic and how widespread it was and how much work needed to be done, the ICS had great wisdom in terms of setting broad overarching objectives and also allowing operationalization by the stakeholders at the front line. I think 2 specific examples stand out in my mind. So, as far as how to absorb the surge of patients coming to the emergency department and how to treat them in a safe manner, kind of the basically deferring to the expertise of the ED leadership and nursing to design and operationalize a standalone trailer, negative pressure trailer outside emergency department to process and test medically stable patients for COVID-19 was a great success. I also, as far as the PPE shortage and the need to conserve PPE, particularly N95 respirators, there was a group that was charged with kind of looking at the options for disinfection of N95 respirators and really kind of ran with that in terms of designing a process. We kind of decided on a hydrogen peroxide disinfection of N95s and then developing this very high throughput process of collecting, handling, and returning N95s to their original users. And really, I mean, it's just people really stood up to kind of answer the call and achieve these objectives.
Yeah, I think those are really great examples. We think about our healthcare workers and again, how agile and flexible they had to be to do different roles, but also that just keep showing up in the midst of surge and kind of navigating that whole, the mental health perspective too. And I'm sure that you guys did a lot of creative things in that regard as well. So I don't know if anybody would want to speak to how you kind of went about supporting your workforce a little bit in this.
There certainly were a number of initiatives that started rather early into the first activation. We actually identified and reached out to our behavioral health administrator, who quickly put together a task force, multidisciplinary, and some of the things I can highlight, and I probably will not capture all of them, but I particularly remember them identifying a cart that they had all kinds of, I apologize, that they had all kinds of the candy and gifts and tokens that had been donated and obviously screened for this purpose. Jason, do you remember the title of that cart? Because they had a catchy name for it, something.
I think it was the Take Care cart.
Take Care cart, exactly. Perfect, thank you. But they organized rather quickly and mobilized that cart, and a number of volunteers, mostly leaders, accompanied the cart, and they had designated areas that they mobilized not just in the night shift, but also on the weekends. And they reported out, became part of, obviously, the incident command report out, and the response to this initiative was significant. I also am aware of Text Your Buddy. That's another initiative where leaders volunteered to identify staff members that they connected with and then continue to support each other. Sometimes that was nicknamed as wingman, who's your wingman, etc. And Jason, are you able to articulate some of the other initiatives?
I want to speak deliberately to one from the first activation, that it kind of emerged as recognition for consideration for mental health from our frontline staff. And as we were starting to demobilize, we're collecting feedback and strengths and improvement opportunities from our incident command team and our executive leaders. But it was Maggie, as in her capacity through incident command, recognizing the need to communicate with our frontline care providers. So we started standing up just debrief sessions and hot washes with these frontline care providers for units that were 100% COVID. And it was that process of just saying what worked well, how can we communicate, that we recognized that it was a lot of times the first opportunity that someone had sat in front of the care providers and asked, how are you doing? And just the gravity of that really sunk in. And Maggie, please speak more, as you were kind of the facilitator for a lot of those sessions. But we recognized the need to have just that informal opportunity for them to decompress and to take what they've experienced, what they've internalized, and probably not processed in a meaningful way, giving them the opportunity to do that. And through the second operation, through the initiatives that Emma spoke to, we've strengthened those opportunities with professionals that can provide counseling resources, and not just program managers or other leaders that's not their specialization, that's not their expertise. So now they've been coupled together to provide even more meaningful services to not just our frontline care providers, but everyone who's had a role in this response and recovery operation.
Yeah, we actually commenced, and I'll hand this off to Maggie as well, because she supported this initiative. But on a previous activation, the after action report, we summarized a need that had been called out to support our JIC members through the duration of an activation. And we had started this process, and as all new programs, take time, we were actually celebrating as we have finally secured all of the moving parts and found a qualified vendor who's available and with qualified staff to support our JIC leaders and our JIC members as appropriate, and making them aware of their service and allow them to talk about their experience. And as Jason mentioned, in a not just a well-being manner, but also in a productive manner, where any lessons learned or heightened awarenesses that may have occurred during that person's tenure are shared and ultimately will be summarized for the after action folks to implement accordingly. And Maggie, if you'd like to add anything to that, the door is wide open.
Yeah, absolutely. I think both, Jason and Emma highlighted really well the two programs that we focused on. I think one of the things that was really interesting about the frontline provider debrief feedback sessions that we conducted as well is that we made sure to have representation from every COVID unit that we had open. And we had quite a few open during the spring that were dedicated just to COVID patients. But we also worked to have representation from every provider type. So we talked to nurses, nurse managers, residents, fellows, attending physicians, respiratory therapists, and made sure that we had a full breadth of provider experience as well. And I think, that really provided, as Jason highlighted, a wonderful opportunity for someone to sit down and ask these providers, how are you doing? How are you handling this? How can we support you better? And we really saw those lessons learned highlighted very nicely throughout our after action reporting process. And I've seen some swift and exciting movement to move on those actions, which has been really beneficial for the second activation. In regards to the efforts to support EOC staff and in their kind of mental health support as well, I think this was a really interesting opportunity for us, as we've taken a lot of time to debrief and get feedback from those responders, but not necessarily just ask, how are you doing? How's life at home? Like, are you doing okay? And as each of us know from having been responders, we often don't want to, we're not going to come out and say it and talk about it, but if somebody asks us, it's a really important opportunity to make sure we're taking care of ourselves so we can continue to take care of others. And I think both of these efforts that we worked on, I look forward to working to incorporate into our emerging infectious disease program in the future for potential future events.
Those are great examples, you guys. I think about how powerful the debrief tool is, but it's something we don't use day to day in our environments in healthcare. And it's so powerful, whether it's a difficult trauma, the death of a pediatric patient, or just any sort of incident in general. It's really a powerful tool, and it sounds like you guys really applied it in a big way, both at the individual level, team level, EOC level, and organization. So that's really cool. All right, let's move to a question. I think one of the things we've all seen as we've transitioned through the pandemic so far is there's been tremendous amount of innovation and success as we've gone about our implementation of new strategies, new ideas. So is there anything that you guys are going to hold on to? And I'll start with you, Maggie. Are you going to hold on to anything when the pandemic is over that you sort of innovated on or found to be useful? We talked about one just now, debriefing, but what else?
Yeah, absolutely. So I think that we will definitely hold on to those two debriefing topics. Yeah. We will also likely hold on to some of the work that our workforces have done throughout the span. So I know we've got, for example, a workforce currently working on development and operationalization of crisis standards of care. Whether or not we have to activate that and use that this time, that is an innovation and a project that I fully intend on us continuing to hold on to and develop. It's been a great work in progress to make sure that we have that ready should we need it. I hope we don't. However, the next time a potential pandemic comes, we don't want to have to rewrite that from the beginning again. And so I think we've had quite a few, that's one example, but I think we've had quite a few developments that have been really strong and have been incorporated through that after action process that I know that we'll plan to continue to incorporate in the future.
Maggie, a quick question just on the heels of the crisis standards of care. So many of our states in the Midwest didn't have crisis standards of care. We didn't have any that existed for our state. So a group of us from our state got together, created it. But do you guys have crisis standards of care, like a big overarching plan in your state? And then what you were doing was really trying to apply it more at the local level? And how would you use crisis standards and implement those in your own facility? Is that sort of what you were doing?
So this may be something that Jason can talk to, but to date, there has been a St. Louis metropolitan effort within the many hospitals in the area to create a regional level agreement on crisis standards of care. And then I've also been working on the Barnes-Jewish Hospital team to create the implementation workflow and operationalization of what that regional flow would look like at the hospital level.
Great, thank you.
And Shelley, your assessment of Missouri is correct, that we did not have any statewide guidance or protocols that would support crisis standards of care. So as Maggie mentioned, we initiated those efforts at a regional level, and that was interfacing and coordinating those difficult decisions with our other health system partners in the region that support the same community as we do, and making sure that we were load balanced and just on the thresholds for implementing some of these decisions, and making sure that we were messaging that in a meaningful way that understood the context, the circumstance, that wouldn't create any frustrations or anxieties that or exacerbate those anxieties within our stakeholder groups that we serve. So it's another component that just prompted some difficult discussions, but also gleaned opportunities for greater cooperation. So
right.
Opportunity.
As we think about crisis standards too, it's not just a pandemic where we might see the need for this, right? So it might be, some sort of large scale mass disaster event, who knows,
Absolutely.
right? So it's kind of nice to be able to think about having some sort of structure that you've worked through to be able to grab onto in those circumstances too. So from the rest of the team, Stephen, we haven't heard from you for a few minutes. What do you think are some of the innovations and successes you'd like to hold on to after the pandemic?
Maybe not so much innovations, but a return to the basics. I think this preparedness mindset of all clinicians in general. I think for years we've kind of just skated by as far as when it's influenza season, the use of appropriate respiratory precautions and so forth. I think this has been a big wake-up call for all of us working in a clinical setting. Probably also this concept of presenteeism, which we're all used to as healthcare workers, and working until you're just about on death's door and about to drop, but really taking a step back. I think the medical screening that we do every day now, maybe it won't necessarily exist in that very rigor, that degree of the form as far as actually having to complete a survey every day, but doing that self-check before you leave for work, and remembering that it's more than just you. It's also your healthcare, your colleagues who are working with you, who you could potentially, potentially transmit infection to. So I think that certainly this preparedness mindset and avoidance of presenteeism are things I hope will be carried forward.
Your back to basics clarity there is so powerful and so true, right? I think it doesn't matter what it is, measles, influenza, whatever it is, we hopefully have learned a lot and can hold on to that. So thank you for that. Okay, let's move on to the 3 S's. And actually, sometimes I like to think of a 4th S. So space, staff, and stuff. And then a 4th one I like to add is systems. So when you guys think about the 3 S's, space, staff, and stuff, which have been your biggest challenge and how have you been able to mitigate it? So it might have been different in phase 1 of the pandemic or the first surge versus the second surge. So I'll let you guys speak to that. So Jason or Emma, you guys want to start?
So I will say one of our largest challenges was the overwhelming thoughtfulness of our community members. And I don't think we were activated a week. I think it was a matter of days that we started literally having things delivered to our EOC door. And all of a sudden I realized that there was more than one reason why there was access control. We had, it was N95 respirators, which we obviously welcomed, but we had boxes of N95 respirators delivered. And that seemed to evolve into homemade masks that were delivered and, by the trash bag full. food and food and food. And I do remember discussions in the EOC about criteria that needed to be established for these donations that were not only showing up at our portal of entry, but also the emergency department was notifying us that they just got a delivery of. So I would say one of the things that we learned very quickly was that we were not very prepared for the donations. I would say that it was another remarkable outcome of our incident command to establish the criteria, actually allocate resources and perform a structure in our logistics branch, our logistics operation. And it didn't take long where they quickly figured out what food sources we would accept. And they put a very structured process in place that tapped into these are the units, or these are the care areas that will receive blah tomorrow, and on Thursday this area is receiving blah. And the logistics function also reported out each day what had been received and where it was going, or what had been coordinated, and how well received it was by the recipients of those donations. So that was something that we didn't anticipate. And I believe we rallied very quickly, and it will be sustainable going forward. Jason, anything you'd like to add to that?
No, I say no, and then I want to start talking. So, no, I'm glad that you hit on kind of the challenges of the donated goods, because that was one that we did not anticipate in any of our pre-COVID planning operations. We had always mentioned it, but we didn't expect the volume and the diversity of goods that would be sent to the hospital.
And it came under stuff.
Nope. And the challenge did change between the first and the second operation, as you mentioned, Shelley, with our S's, and that, we had stability behind our resources and supplies in the second operation. And because of healthy supply chains, we received less of the donated goods, but our staff was affected in ways that we've talked about already, just emotionally and physically, with the viral presence in the community that was, exponentially more than what we even saw in the spring. Our staff were going down, and we had the space, we had the resources, we had the bed, but we didn't have people that could provide care. So that exacerbated some of the challenges regionally with COVID in the second operation that we're in now.
Yeah, and then we ended up, having a lot of competition amongst every state, right? And really difficulty. I remember having conversation with the Midwest states on a state hospital association call about, what were our options for staff, because there just weren't travelers available. There wasn't really necessarily FEMA resources available. So, and we weren't quite at a spot where we needed to have all that help as New York was in the spring and others were afterwards, but we were on the bubble, right, in the Midwest. So I think you're absolutely right. I think that's a big gap that somehow we need to think about how that could be filled going forward. And a pandemic is unique. With other sorts of disasters that are more local, we obviously would get people from everywhere, and that's an issue in and of itself. But as we as emergency managers know, but this was unique and different. And I remember being really nervous about the fact that we didn't have many options, and that's never a good feeling. So.
It was the staffing shortages that were driving a lot of our crisis standards of care discussions.
Yes.
Right. Yes. That was the S that was going to put us over the edge, in the October-November timeframe. So I want to kind of finish with a big question, and I want to hear from all of you guys on this. 2020 is now in the rearview mirror, not by very far, and not because the pandemic's over, but because it's in the rearview mirror. So what reflections would you leave our audience with as we close out today and this podcast? What would you say has been like your biggest reflection of what might be as it relates to kind of doing that retrospective look back? So Emma, I'll start with you.
Retrospective look back for me would be how the healthcare system and our organizations, how much they have learned as a result of this pandemic, and the shifting that has already occurred with collaboration with our community partners, our agencies that support us, obviously collaborative efforts, with our state government, et cetera, pandemic readiness, but the awareness that has occurred in our organizations that possibly will impact planning and priorities going forward. For instance, designing new spaces, the emphasis on ventilation support, designing new spaces, the room, where are we putting our PPE so it's readily available? How are we managing smartly? How can the design support our purpose in the event of a pandemic or any surge activity into the organization, such as how we experience what we experience. I was listening to Dr. Liang a few minutes ago, and I was celebrating when he referenced the N95 respirator. He did not call it a mask. And prior to this pandemic, I think I heard the safety officer say almost 1 million times during the first activation, the N95 respirator, anytime she heard somebody say mask. During the second activation, not that we didn't hear the word mask, but we heard more people referring to the respirator as the respirator. I believe the awareness of employee safety in the work environment, keeping our workforce whole and healthy, whether it's physical, safe from physical hazards, health hazards, and the engineering controls that we can build in to help ensure their safety while at work. And also a heightened awareness about accountability and ownership. So,
Well, I hope Emma didn't take them all. She packaged a lot of things in there. So I think we all.
I'm notorious. I'm notorious for packaging, being in sync, saying it concisely. So they're used to this. And Jason and others are ready to go.
I think we learned more about HVAC. Everyone in our health system learned more about HVAC than they could ever hope to in this whole thing. So and PPE. So Dr. Liang, you want to go next? What were your reflections?
I think certainly, I think one of the things that I've learned is the importance of establishing and preserving unity of purpose, both from an emergency management leadership standpoint and aligning with the entire healthcare team, and the importance of information sharing up and down, between ICS and the frontline and clinicians and back. This this team that Emma, Jason, and Maggie have led have really been, really succeeded at inclusivity, involving subject matter experts, involving safety at the table, occupational health at the table, having those folks input. It's really, they've created an amazing response to the pandemic here in St. Louis.
Thank you very much. Jason, we'll go to you next.
Kind of as I reflect on the pandemic so far and even what's ahead, something that I've taken away and internalized is the opportunity to connect the emergency management dots and to bridge gaps between our expertise and our team members, to our executives, to our non-traditional partners. As everyone has mentioned, like everyone had some exposure to our COVID response and recovery operations, whether they were on incident command or not. But being able to provide awareness of what healthcare emergency management is and the service it provides, being able to connect concepts and planning discussions to disaster operations. I can't even count how many moments there, I had just discussions and updates with our leaders of like, oh, Jason, is this what you were referring to when you said, recovery time objectives for deferred services? Or is this what you meant by span of control, that one person can't lead 20 different people? And having those aha moments and seeing the connecting, and the light bulb come up really was encouraging. It was kind of reinvigorating for my purpose and the roles that we have within our organization and our system. And I think we're seeing the dividends of that, as our leaders have actually expanded the emergency management department at BJH by 200% as a result of COVID and the lessons learned. They've invested resources, funding, and engagement now at a level that we never saw, and I don't think we would have seen if it wasn't for COVID. In our field, we have that phrase, "Don't let a good disaster go to waste," and COVID is not the exception.
And I would add to that, something very important is that the executive leadership recognized, obviously, the effectiveness, the level of effectiveness, competence, efficiencies, deliverables that Incident Command met and was successful with throughout the duration of the activation. Well, with that being said, of course, if you do something very well, there's always a consequence. So all of a sudden, Jason and I found ourselves challenged with assisting our leadership team with transitioning emergency management principles for operation into application to the GDP goals. And they wanted to embrace the terminology. They wanted to embrace the line of authority or the whole framework. And I remember looking at Jason as, obviously I'm in a support role and a pave the way role for all of our team members. And I remember looking at him and I must have looked like, what are we doing? How in the world is this possible? And of course, I won't say leadership, executive leadership was very much excited at this concept that they had actually approached us with some timelines. But I would say our middle management directors, such, were like, what? It was, I won't say it was in the beginning warmly received. However, I will say that we did transition our operations to the GDP goals, and they went forward. Hey, Jason, you probably participated in more of those operations meetings than I did, but anything you'd like to add?
I think our leaders learned the lesson that Incident Command is not a stable and permanent management structure, that it is exhausting and it's challenging, and there's a reason we use it only for disaster. But I think they found the compromise to take some of the risk-taking behaviors. And a phrase we had used throughout our response was solve for 80%. And they would take that 80%, solve it, push it, and then just kind of monitor behind the scenes. And I think they've adopted that kind of forward-leaning aspect of Incident Command with the same cadence that's maybe more appropriate for standard work.
Yeah. Good examples, you guys. I also think about, in our world too, we've always got to be thinking about business continuity and what about the disaster within the disaster. So we won't spend time on that today, but we could come back to that at some point, maybe round two. But really having redundancy in the ability to operationalize the command structure for two simultaneous events. So doing an event in the midst of COVID in and of itself is a huge endeavor, right? Because everything changes, evacuation changes, processes change, so many things. So we'll hold on that thought and not wish that upon us. We did have a cyber event here about a month and a half ago, but it gives new meaning to having some redundancy in the structure. So I want to finish with Maggie as a member of our special pathogens group and having led efforts there, and just ask you, Maggie, to reflect on your 2020 and maybe your hope for 2021.
So my reflection is really truly that while 2020 may be in the rearview mirror, this pandemic certainly is not. Just because we've turned over a new year doesn't mean it all magically goes away. I think a lot of what this pandemic has taught us, not only on the clinical side and the emergency management side, but even on the personal interaction side, are some activities that I really hope to see continue for a long time. I can unfortunately say with 95% certainty that this will also not be the last pandemic we see. And, you know, I think from an emergency management perspective, response is always the really exciting one. You know, getting to do a deployment, do an activation is what, you know, a lot of people look forward to. But I think preparedness and mitigation is really what helps us attack these problems head on and be successful at it. So what I would encourage the audience to do, what I have been really excited to see this team do, is take lessons learned from these activations, from these responses, and actively apply them towards our preparedness plans and efforts. I certainly know that we will be much better prepared for the next event.
Thank you. I really want to thank our panel today. You know, as I think about 2020 and sort of the rearview mirror, I said it was a lot like looking into a camera and the lens isn't quite in focus. You know, it's not still in focus as we've moved into 2021, but I think as a nation, as a state, as individual organizations, we have got to learn from all these things. And you guys have articulated many examples today of which I just know, you know, you're going to hardwire into the future for success. And I agree with you, Maggie, this won't be the last pandemic. Unfortunately, I had to lead through one in H1N1 back in 2009. So I said, It's just not fair that an emergency manager, and you guys probably fit this bill too, ever has to lead on more than one pandemic in their career.
Right.
But anyway, with that said, we're just going to hope that we're able to, as a nation and individuals and organizations, learn from this and constantly be in the pursuit of improvements and moving forward in a very positive way to be able to respond to whatever's next, and there will be something next. So with that, I want to thank everybody for joining me today. This was a great conversation. You guys have obviously done a tremendous amount of work, and very excited to see how you were able to successfully, and still are, in the midst of response and learning from everything as you go.